All right, welcome everyone. Welcome to the final week. It's been a great term, hasn't it? The time really does fly, and so congratulations to the final week. I'm sure you're all excited. I am too. I'm excited for you. So it's last lecture, one more exam, and then you can enjoy a little break. Okay. All right. So. In terms of the reproductive system, what I'd like to do first is just do a very short, brief tutorial review on some of the main anatomical landmarks of the male and the female reproductive, so that when you hear of some of the diseases, some of the tumors, some of the infections, and some of the symptoms, it just makes a little bit more sense for you, okay? So when we look at the male reproductive, we could start at the bottom over here. You can see we have the scrotum, which houses the testes, and just above the testes is the epididymis, and then connected to the epididymis is the vas deferens, aka ductus deferens, which comes around here, and you could see the seminal vesicle releases semen, and then you could see we have the ejaculatory duct here. This structure here is the urinary bladder. So it releases urine through here into the urethra. This is the spongy urethra. Here is where we have some semen and sperm that can come through here. So they both end up going through the same spongy urethra upon exit. This gland right here is the prostate gland. And that's an important structure. I want you to pay close attention to that. So when urine starts to downflow into the urethra, there's the prostatic urethra and then the spongy urethra. If the prostate gland enlarges, it doesn't just expand outward, but it compresses the ductwork here. So the person may feel the urgency to go urinate, but there's the hesitancy, meaning they try and go and they just can't. And that's due to compression of the prostatic urethra by the prostate gland that could be enlarged. All right, and we'll talk about prostatitis and benign prostatic hypertrophy. What else do we have? So the testes here is where sperm is made, and then they get to mature here, and then they're stored here. The gland's penis is the tip, and here is the external urethral orifice, which should be on the tip of the penis. Sometimes we'll see it on the upper surface, sometimes congenitally it could be on the underneath surface. Okay. All right. Here is a close-up view of the testes, and you could see we have the seminiferous tubules, and this is where sperm are actually produced in the inner workings here. And then we have this structure here called a spermatocord, and the spermatocord houses a lot of the blood vessels and nerves. And that's an important concept because we'll talk about certain issues that can arise when this gets all twisted up and torsioned up. Besides the blood vessels and the nerves, we have the vas deferens or the ductus deferens that also travels through with this. Okay? Very important to understand about the capillaries in here and the blood vessels. The veins here, they do have valves, so we want to make sure that these valves work. Otherwise, you can get this backflow of blood in here from the dilated vessels and get an accumulation of fluid in this area. And we'll talk about that as well. Here in this view is another perspective of the urinary bladder. We can still see the seminal vesicle. Here's the prostate gland, and here's the prostatic urethra. So you can understand that if this enlarges, if the prostate gland enlarges, it can put pressure on the prostatic urethra, obstructing and blocking the flow of urine on its way out. Again, another view here, we have some deep muscles that can constrict to stop blood flow, to stop the urine flow, or open up to allow the flow of urine through here. Here's the prostate, prostatic urethra, and then here's the spongy urethra. We can see that there are blood vessels that go through the corpus cavernosum and corpus spongiosum in response to nitric oxide. These blood vessels dilate, they engorge with blood, and helps the male maintain an erection. Let's look quickly at the female reproductive tract. Let's get oriented with what we see here. Here's the pubic bone, so this is anterior. Here is the anus, this is posterior. And we can see that there are three roots. We have this canal or this channel, that's the external urethral orifice, so this is the urinary bladder. Urine comes out of here. Here is the uterus, so baby comes out of here. And then here is the colon, so bowel and feces come out here. Okay, we understand the importance and significance of when a woman uses the restroom and needs to wipe herself, the importance of wiping from anterior to posterior rather than posterior to anterior. Okay. Here is the uterus. The uterus has a few different layers. We remember from A&P the endometrium, the muscular layer, myometrium, and the perimetrium. The tip of the uterus is called the cervix. So this is important to know when we talk about cervical cancer, uterine cancer, or the ovary, and we talk about ovarian cancer. Here's the fallopian tube when we talk about certain diseases that are involved with inflammation of the fallopian tubes. So we can see that here's the fallopian tube, here's the fimbriae, and then here's the ovary. Another perspective, you could see the vaginal canal and the rugae of the vaginal canal. Here's the tip of the uterus called the cervix. The fornix is the indented portion here. We could see the endometrium, myometrium, and the perimetrium. We could also see the fallopian tube, and then the fimbriae, and then the ovary. So in terms of fertilization and implantation, sperm come in here. They can be stored here in the fornix for a while. Then they move their way in to the uterus. They start chugging along here. Remember, the body of a sperm is mitochondria. So there's energy that helps to propel and whip around the flagella, the tail. And finally, the sperm hopefully makes it here into the fallopian tube, whereas the egg comes this way. And then somewhere in the fallopian tube is where fertilization should take place, and only fertilization, not implantation. Then the cilia are beating rhythmically in this direction to push the egg that's been fertilized somewhere here for implantation. Okay, somewhere in that endometrium where there's carbohydrates, proteins, and fats. All right, now let's start with the male reproductive. Now that you have a pretty good understanding, we're going to talk about some of the congenital abnormalities of the penis, some disorders of the testes and the scrotum, and then inflammation and infections. So there is a condition called epispadia and hypospadia. These are congenital abnormalities. Epi means above. This is when the urethral opening is on the upper surface of the penis. Hypo means under. Hypospadia is when the urethral opening is on the underside of the penis. Either condition may result in incontinence or infection. And the treatment for this is surgical reconstruction. So here's the shaft of the penis. This is normal where the opening is at the tip of the glans penis. Here it's on the underneath surface. This is hypospadia. And here the urethral opening is on the upper surface. So this is hypospadia and epispadia. Okay, now we have a disorder of the testes and the scrotum. This is called cryptorchidism. cryptorchidism. Now, this is a condition where one or both of the testes fail to descend, right? The failure of the testes to drop, and they can remain in the abdominal cavity or somewhere along the descent pathway. The testes may descend spontaneously within the first year of life. Now, this does require surgical intervention if the testes have not descended by the time the child is 2 years of age. Otherwise, this condition can lead to infertility and testicular cancer. So what we can see right here, the testicle forms in the abdomen and descends through the peritoneal space during the last few months of fetal development. Here, the testy remains in the pelvic cavity. Here, the testy can remain in the inguinal canal. Here, the testy can remain in the upper scrotum. So anywhere in here, these are possible abnormal locations for the testes to reside. The normal location, we need the testy to drop fully and to remain in the scrotum. And there is this septal wall that separates one testy from the other. Okay, cryptorchidism. Hydrocele, spermatocele. These are still disorders of the testes and the scrotum. So hydrocele sounds like something to do with water. Spermatocele, well, something to do with the sperm. So let's take a look. Hydrocele occurs when excess fluid collects in the space between the layers of the tunica vaginalis of the scrotum. We're going to see this between the visceral layer and the parietal layer. It is congenital defect in the newborn. It can happen later in life if there's an injury or infection or tumor. And the problem with this is it can compromise the blood supply or the lymph drainage in the testes. So if we look here, here's the testes. Here is the epididymis. Epi is above. There's the epididymis. And then here's the vas deferens or the ductus deferens that will continue from here and go all the way up. Okay? From the epididymis all the way up. Now what we're looking at here all the way around, this is the scrotal sac. Okay? And inside we have the testes, the epididymis. This is where sperm are going to be produced, and here is where they're matured, and then all the way going up in the vas deferens, aka ductus deferens, is where the sperm will be stored. Now, here is a hydrocele. It's a clear collection of fluid in the space between this layer here, which is the visceral layer, and this layer on the outer part, which is the parietal layer of the tunica vaginalis. Okay, remember the portion of the membrane that comes into contact with the organ or the gland is known as the visceral layer, and the layer on the outside is the parietal. And all this is hydrocele. This is a lot of pressure. This is a lot of pressure that can block the blood vessels, and that becomes dangerous, and it can cause necrosis, ischemia, and then necrosis. Now, variocele sounds like a varicosity, right? Similar, a varicose vein, varicocele. This is a dilated vein in the spermatocord, and it's more common on the left side. And when there is a lack of valves, it allows that backflow of blood in the vein, and that can lead to increased pressure and dilation. That could cause impaired blood flow to the testes and decreased sperm production. Spermatogenesis. This does require surgery. So here, varicose veins, right here is the veins. Here is the spermatocord. And here you could see that these are dilated. The valves are non-functional, so there's this backflow of blood moving this way, creating a varicocele. Right? When you have the backflow, we know that that becomes dangerous. We've discussed about this in several other topics. They'll swell up, you'll get edema. Now, testicular torsion, this is when the testes rotate on the spermatocord. When they rotate, You're going to get compression of both arteries, veins, lymphatics. This can be spontaneous, or it can also follow trauma. That will result in ischemia, right? Lack of blood, lack of oxygen, and the scrotum will swell with all the backflow. The testes may become infarcted if that torsion is not reduced. So here is the testes and the epididymis, and you can see this is just really wound up. This is called testicular torsion. This will compress all the blood vessels. Now let's talk about some infections. Prostatitis. This is an inflammation or infection of the prostate gland, and it's an ascending infection. It's going to be moving upward. And there are 4 categories. There's an acute bacterial, non-bacterial, chronic prostatitis, and asymptomatic. So the acute bacterial, this is when the gland is tender and swollen. And urine and secretions will contain some bacteria, they'll contain pus, and there'll be evidence of white blood cells. The non-bacterial, there'll be elevated white blood cells in the urine and prostatic secretion. The prostate is going to be slightly enlarged with non-bacterial. Now the chronic bronchitis, this one is related to repeated infections of E. coli. E. coli seems to be the major contributor here, okay? The prostate will be slightly enlarged, it'll be irregular, and it will be firm from fibrosis. Now, in order to detect whether or not it's firm, this is where the physician has to do a digital rectal exam, and the finger has to go in and palpate the lobes of the prostate to determine this. It's asymptomatic in the inflammatory phase of it. The etiology is going to be for the acute bacterial prostatitis, which is very, very common. Remember, it's an ascending infection, E. coli. E. coli is the most common and often cause. I want to stress that. And there are some others, I mentioned them below, but E. coli is the most often trigger for acute bacterial prostatitis. There's Pseudomonas, Proteus, Enterobacter, Klebsiella, Serratia, and Strep. Some of the risk factors for prostatitis, it can occur in young men with recurrent urinary tract infections. It can happen in older men with prostatic hypertrophy. It is also associated with some sexually transmitted disease, what we will talk about in this topic. Sometimes it can be a complication when instrumentation is being used, such as catheterization. And bacteremia can also be a risk factor. With acute and chronic infections, there's going to be dysuria, will be, painful urination, urinary frequency and urgency, like they have to go and they have to go right now. With the acute form, there will be fever and chills. There'll also be lower back pain and lower abdominal pain, close to the groin. There'll be decreased urinary stream, hesitancy in initiating urination, meaning they really have to go, but when they go and they try, there's hardly anything that wants to come out. And there's also incomplete emptying of the bladder. Incomplete emptying of the bladder also creates this, feedback loop of the feeling of they have to go again and they have to go urgently. The systemic signs are going to be fever, malaise, anorexia, and muscle aching, again in the lower abdominal region. The non-bacterial prostatitis, the urinary signs are present that we discussed before, but the systemic signs are going to be less marked. With prostatitis, the treatment here is going to be bacterial and anti-inflammatories. Okay? And we'll finish up with the last one, balanitis. This is when there's a fungal infection of the glans penis. This is an STD, a sexually transmitted disease caused by Candida albicans. Vesicles will develop into patches. There'll be severe burning and itching, and the treatment for this is a topical antifungal medication. Okay, when we come back, we will start the topic of some tumors. And we'll talk about BPH, which is benign prostatic hypertrophy. We'll talk about prostate cancer and testicular cancer.